at Manchester Royal Infirmary. I've been asked to put together a short presentation on the guidance for referral of head and neck cancers with an emphasis on the ENT side of the disease. I've been asked to look at the top 5 symptoms for head and neck cancer, and these can be found on www.nice.org.uk under the referral guidelines for suspected cancer. These have recently updated and are an extremely good source of information for clinicians looking to refer patients. 40% of people with a lateral neck lump over the age of 40 will turn out to have some form of cancer. It's especially important to pay attention who complain of sore throats, which particularly radiates to the ear, especially if this is beginning to interfere with eating and drinking. Solids are usually affected first, and patients often come having had to resort to soft diet or fluids as the pain is so bad. They often have associated weight loss. If the pain is unexplained and you can't see anything, particularly if it's unilateral earache and otoscopy is normal, these patients also qualify as a 2-week wait referral. With regards to salivary gland swelling, this includes parotid and submandibular gland, and if there is a persistent swelling in this area that hasn't changed over, again, a number of weeks, these patients should be referred urgently. Long-standing swellings are less likely to represent malignancy, but one should be especially aware of associated symptoms such as facial nerve weakness, pain and skin changes. Lastly, I'd like to talk a little about thyroid nodules. Thyroid nodules are common in the general population. Anybody with a thyroid nodule that has recently changed in size, has a history of neck irradiation, family history of an endocrine tumour, hoarseness or voice change, associated lymphadenopathy, or is less than 16 or over 65, should be referred urgently as a 2-week wait. If they have stridor and evidence of tracheal compression, they should be referred on the day to their nearest ENT emergency service for airway management. If the thyroid swelling has none of these features, we'd like you to do thyroid function tests. If the patient is hyper or hypothyroid, they can be referred routinely to an endocrinologist. And if they're euthyroid, they can be referred routinely to the local thyroid surgery team. I'd like to now illustrate some of these features by talking through some recent cases. Case 1 is Mr. Fitzgerald, who is a 78-year-old gentleman. He gave his GP a 6-week history of sudden voice change. He had no other symptoms, but had smoked 20 cigarettes per day since he was 18 years old. He had a background of COPD and was being treated with some inhalers. Drank a moderate amount of alcohol. His GP sent him for a chest x-ray, which was normal, so he was referred under the 2-week rule to his local ENT department. The history in the ENT clinic was much the same. However, fibre optic nasendoscopy in clinic showed the above tumour. This is a tumour arising from the left posterior vocal cord extending onto the left false cord. This was biopsied in theatre and proven to be a squamous cell carcinoma. Mr. Fitzgerald received radical radiotherapy to this area and came through treatment very well, and I'm pleased to report he's doing fine as this tumour was picked up early. Case 2 is Mr. Jones. He is a 50-year-old gentleman who gave his GP a 4-week history of a painless left neck mass just anterior to sternomastoid. He had no other symptoms, was a non-smoker, drank a very small amount of alcohol, and had no other past medical history. He was referred up as a 2-week wait, and on full ENT examination in the ENT clinic was noted to have a lesion within the left tonsillar fossa. This was biopsied and shown to be a squamous cell carcinoma that was positive for the human papillomavirus. You don't need to see a primary to refer neck lumps, but you may do if you have a little look round. The commonest site of unknown primaries is either tonsil or tongue base. One should maintain a high index of suspicion even when we are dealing with young patients who do not smoke or drink with lateral neck masses, as the HPV virus has certainly lowered the threshold for us finding cancers in this young population. In fact, oropharynx cancer last year for the first time became the commonest head and neck cancer and overtook larynx, and this is due to the virus inducing tumours in young susceptible people. This gentleman was treated with chemoradiotherapy successfully, and I'm pleased to report that currently is free of disease. HPV-induced tumours do tend to do better and respond to treatment in a better fashion than those that are HPV negative. The next case is that of Mrs. Connolly, a 67-year-old lady who had a 6-week history of left-sided throat pain which radiated to her ear on swallowing. The GP noted that her ear canal was normal, there was no wax, and she had a normal tympanic membrane, but she described only being able to manage a soft diet and had lost 5 kilograms over the preceding 6 to 8 weeks. This lady was a lifelong smoker of 40 cigarettes a day and had severe COPD on maximal treatment. This lady was appropriately referred as a 2-week wait, and in an ENT examination clinic, there was no tumour to be seen, despite flexible nasendoscopy being performed. Given the high index of suspicion given her symptoms, she was listed for an examination under anaesthetic, which revealed a left-sided piriform fossa tumour as seen in the picture on the right-hand side. This was biopsied and proven to be a squamous cell carcinoma. Despite her comorbidity, this lady was given radical radiotherapy and has come through that well, and is now managing a soft diet and is free of disease. The next case is a young 28-year-old woman who presented with a left-sided parotid swelling and some left-sided facial weakness to her GP. She was otherwise well, didn't smoke, and was referred urgently as a 2-week wait referral given the facial palsy and the GP maintaining a high index of clinical suspicion. She was seen in her local one-stop neck lump clinic. Noted to have about 50% facial nerve function, she did still have some slight movement and a 3 centimetre painful left-sided parotid swelling. She had an ultrasound that morning with an FNA with a fine needle aspiration performed, and the result of that given an hour later was suspicious for malignancy. She was booked for cross-sectional imaging, discussed in her local MDT, and offered a total parotidectomy for a malignancy. Unfortunately, her facial nerve was involved with tumour, but she's undergone some facial reanimation procedures and continues to do well. The last case I'd like to discuss is a 45-year-old lady who recently noticed a right-sided thyroid swelling increasing in size over 2 weeks. She had no family history of previous irradiation, she had no compression symptoms, lymphadenopathy, voice change or stridor, and she was otherwise well. She was referred as a 2-week wait, and thyroid function tests done by her GP had shown her to be euthyroid. She was again triaged as a 2-week wait into a neck lump clinic, and an ultrasound-guided FNA was performed in clinic. The ultrasound was graded as U2, not suspicious, and her FNA reported an hour later was reported as Thy2, benign cytology. British Thyroid Association guidelines allow us to discharge patients after these investigations, and as the patient wasn't keen on surgery and was reassured completely, she was happy to be discharged to the care of her GP. It's not necessary for primary care practitioners to request ultrasounds on thyroids they are planning to refer as 2-week waits, as they are often just duplicating investigations that we would do in clinic, as ultrasound-guided FNAC is the gold standard for these patients anyway. In conclusion, if you follow the NICE guidance, this will pick up many patients with head and neck cancer, although it is important to remain highly suspicious and have a low threshold for referral in order to try and pick these cancers up as early as possible. Please get to know your local services. Who runs the neck lump clinics? There's usually 2 thyroid surgeons in each trust. Most patients require no investigations. They merely serve to slow the patient pathway down. The indications for investigation are hoarseness patients require a chest x-ray, and please note thyroid patients do not require an ultrasound. Please use your local pro forma for referral. The more information you can give the clinicians, the better they can triage them into the correct clinic. And if you need any advice at all, please don't hesitate to contact your local diagnostic head and neck surgeon, or if you are under the catchment of one of the big head and neck centres, we are always available for discussion and advice as required. Thank you for your time.